دكتور.
أين أنت يا فراس؟ فراس محمد غياب؟ إيش صار؟ أوكي، ما بعرف شو صار، فصلت رجعت أجين. صباح الخير جميعا.
صباح الورد دكتورة. صباح الورد.
قد إيه عدد الطلاب؟
الكامل؟
نعم
109.
109. لسه في عنا 9 طلاب غير موجودين. طبعا أنا what I do usually 10 minutes and I lock the meeting. please ما حدا بعدين يقول لي دكتورة طلعت ودخلت ومش عارف شو هاي السواليف. تمام؟ once I lock the meeting ما حدا يبعت لي. رقم 1. رقم 2 فراس ما رد. فراس القاضي أين أنت؟ A6 A6 فراس. طيب هلا أنا في محاضراتي كمان in 10 minutes please كل السي آرز يبعثوا الحضور والغياب، وأتمنى عليكم إنه ما حدا يبعث عن حدا حضور وهو ليس حضور. الحضور بيكون مش بس إنه نفتح السيستم، ممكن أنادي أي أحد منكم علشان يجاوب أو علشان يشارك. تمام؟ فبي فيجيلانت، ما نبعث الغياب إلا للناس اللي حاضرين. وما حدا يقول لي السماعة خربانة، ما بيزبط معي كمان. ما حدا يقول لي دكتورة عم بكتب عم بحكي وما بتسمعيني، كمان ما بيزبط معي. أوكي؟ طيب خلنا نبلش. بسم الله الرحمن الرحيم. راح نبلش بأول إشي. نعم يا ريتا. ريتاج نعم.
دكتورة إحنا كيف نبعث الحضور للأسئلة هاي لأنه في ناس شكله مش موجود.
طيب أنا بسألكم، أنا راح أسألك الحضور والغياب، مش أحسن؟ أسهل حياتك يا ريتاج. حسام هشام موجود؟
نعم موجود.
أوكي. عز الدين القسام.
نعم.
ياسمين يوسف.
موجودة دكتورة.
عمر بسام.
نعم دكتورة موجود.
بيان إسماعيل.
نعم دكتورة موجودة.
إيثار عدنان.
نعم دكتورة موجودة.
زين.
نعم دكتورة موجودة.
أفراح.
موجودة
شفتك من
دكتورة.
البداية. وريتاج أنت اللي حكيتي. لجين نبيل.
نعم دكتورة موجودة.
أوكي، يعني فراس كان موجود في محاضرة الدكتورة رامي. الدكتور رامي ما بتعرفه، مش مشكلة. يلا نبلش. بسم الله الرحمن الرحيم. طبعا كويس. it is an advantage إنه صلكم 4 أسابيع مداومين، معناته most of the terms I'm going to use are somehow familiar to you. طبعا لما نحكي على fertility control and contraception, this is something that you've discussed when in your family medicine rotation. طيب إذا fertility control and contraception وسائل تنظيم الأسرة بنفضلها على جملة وسائل منع الحمل. وسائل تنظيم الأسرة. Effectiveness usually of anything we do is usually measured by its success rate. However, this is not the case with methods of contraception where we use the failure rate. Failure rate is measured as failure rate per 100 women years. And this means the proportion of women who will become pregnant within the first year after initiating the method. The proportion of women who will become pregnant within 1 year of initiating the method. This is the meaning of failure rate per 100 women years. It is not the same as percentage. Methods of contraception vary between, we have many methods of contraception, including natural family planning, barrier methods, intrauterine methods, hormonal, and long-acting and reversible methods of contraception. When you take a history, please make sure you ask about all possible methods of contraception. Those who already discussed cases at Prince Hamza Hospital noted that you usually ask about hormonal contraception or IUCD, but never about natural family planning. If you have a couple who's not pregnant, after some time you need to ask yourself, if this woman is pregnant, why? Is it because she's infertile, subfertile actually, or is it because she's using a method and I'm not aware of it? Please make sure you ask about that. Natural methods include cycle or rhythm method, calendar method. الستات بسموها طريقة العد. هذه اسمها طريقة العد. Temperature method. Temperature method can be used either as a method of contraception or a method to check for ovulation and enhance fertility. Cervical mucus, cervical palpation method based on the physiological changes during the menstrual cycle. We have coitus interruptus اللي الستات بيحكوا عليها العزل. طريقة العزل, ejaculation away from the patient. And lastly, we have lactational amenorrhea. Lactational amenorrhea, as the name implies, amenorrhea, no periods in association with breastfeeding. And for this method to be effective, we need 3 criteria, 3 conditions. First of all, amenorrhea, no periods. Secondly, the first 6 months after delivery, and full breastfeeding, exclusive breastfeeding. If these 3 criteria are met, then the success rate or the failure rate is really low. Usually, no pregnancy occurs in 98% of women who are following lactational amenorrhea with the conditions that I've mentioned. If a woman rings you up saying, "Doctor, I had my baby 4 weeks ago," or no, let's say 8 weeks ago, and I'm fully breastfeeding, and I'm reliant on breastfeeding as a method of contraception, but it seems that I had my period today. Can I rely on this method alone? The answer would be no, because we said for this method to be effective, we need 3 criteria: amenorrhea, no periods, and the first 6 months, in addition to exclusive breastfeeding. Other methods include barrier methods, male-female condoms, cervical caps, diaphragms, we have sponges, in addition to spermicides. Spermicides are not used on their own. Spermicides are usually used with other mechanical methods. Hormonal contraception can be combined or progestin-only methods. Combined hormonal contraception includes pills, combined oral contraceptive pills, patches, and we have vaginal ring. Patches are usually transdermal patches releasing norelgestromin and ethinyl estradiol into the systemic circulation for 7 days. And then we have to change the patch after a week and put another one at a different place of the skin. And then after 3 patches, no patch is used for the 4th week to allow withdrawal bleeding to occur.
الحمد لله
سامعيني انه فصلت الشبكة
الحمد لله
ورجعت؟
رب العالمين.
أوس؟
لا مسموع دكتور. مسموع دكتور انه حتى من قبل.
سامعيني؟
مسموع دكتورة.
اوكي تمام. إذن اللي سمعتوني بحكي regarding the patches, we put the patch over the skin for 1 week, we change it, we use 3 patches every week, 1 patch, and we don't use a patch for the 4th week to allow withdrawal bleeding. With the ring, we insert the ring for 3 weeks. We leave it in place. We don't need to change the ring weekly. It releases ethinyl estradiol and etonorgestrel. And it seems that with the vaginal ring patches, they have similar efficacy and side effects as those with the combined oral contraceptive pills, but probably patient adherence and compliance may be better because women do not need to use pills daily. Combined oral contraceptive pills are usually administered on a 21 to 7 day basis, 21 days, and 7 days pill-free interval. This is a sachet for tablets used for 21 days. There are the other preparations where pills are given continuously, but still we have 21 active hormonal tablets and 7 placebo. Usually these tablets include iron and folate. Why some prefer this method? So women do not break the habit of taking pills every day. For the 21 active tablets, the first 7 are the most important because these are the ones to inhibit ovulation, while the other 14 are to maintain anovulation. This is very important when women miss a pill. It helps you decide what to do. Now, with the combined pills, when to start them? We have different types of pills. All of these are available in Jordan. Microgynon is actually the oldest combined pill used over the world and also in Jordan. Usually the combined pills are initiated within the first days of the period. إيش المشكلة اليوم؟
سبحان الله وبحمده سبحان الله وبحمده
ما بعرف شو صار، فصلت كل presentation. نرجع مرة تانية. انتوا مو شايفين presentation، راحت صح؟
صحيح.
اوكي نرجع لها again. Interesting. اوكي نوصل محل ما كنا بنحكي combined oral contraceptive pills. سمعتوني لما حكيت انه we have preparations with 21 tablets, and we have those 21 tablets with a placebo that contain usually iron and folic acid. To start the combined pills, if the woman is menstruating, we usually start within the first days of the cycle, although some manufacturers specify that we need to start on the first day of the cycle. طبعا women who are amenorrheic, can they start combined pills? Yes, they can, provided there is evidence that she's not pregnant. After miscarriages, we can start the pills immediately. After delivery, postpartum, women need to wait for 6 weeks after delivery before starting the combined pills because of the increased VTE risk with estrogen. If the woman is menstruating, as I said, you initiate combined pills within the first 5 days of the period. Side effects usually are minor, but the most important side effect to be discussed, to be disclosed to women before starting the method is the possibility of VTE. Please always assess the risk for patients to have VTE. Make sure that this woman is eligible for taking combined hormonal contraception, and if she is eligible, once you prescribe combined pills, please tell her to stop the pills immediately if at any time she has scalp pain or chest pain, and to seek medical help. Benefits: in addition to contraception, we have non-contraceptive benefits. We have older generations and newer generations of combined oral contraceptive pills. It depends. Once we give the combined oral contraceptive pill, do we need other benefits specifically or not? As in cases of polycystic ovary syndrome, where women complain of hirsutism and acne. We give Diane 35. شايفين صورة البنت اللي وجهها أبيض صافي, to remind you that this is a management option for acne in patients with polycystic ovary syndrome. She requires contraception, and at the same time we're managing her other symptom.
أستغفر الله.
Yasmin is one of the newer generations, and we have Yaz 24 tablets, where we use it mostly for women with premenstrual tension syndrome symptoms. What happens if a patient misses? بلاش a patient, she's not a patient. If a woman misses a pill, if she misses one pill, شو منقولها؟ منقولها don't worry, continue the rest of the packet as usual. Take the missed pill as soon as possible and continue as usual. You do not need emergency contraception. Then, when I discussed a missed pill with a woman, I had to think of 2 points. First, how to continue this method. Second is, does this woman require emergency contraception or not? With one pill, no problems. You remember the pill, take it as soon as possible, and then continue the pack as usual. No emergency contraception is required. Now, if she misses 2 or more pills, the first point, how to continue the method, how to continue the contraceptive effect. منقول للست, take the most recent pill as soon as possible and continue the pack as usual. But you need to use condoms or abstinence. Abstinence no intercourse for 7 days. The second point, does this woman need emergency contraception or not? If in the first 7 pills, she missed more than 2 or more pills in the first 7 tablets, yes, she needs emergency contraception if unprotected sexual intercourse in the pill-free interval or the first week of using the packet. Because we agreed earlier that these first 7 tablets are the most important to cause an ovulation, to stop ovulation. The other 14 are to maintain ovulation. So definitely emergency contraception is required. The second 7 tablets, if she misses 2 or more between 8 and 14, no emergency contraception is required if she took the preceding 7 pills. The last 7 pills, if she misses 2 or more of these, then we tell her to continue the sachet and start a new packet immediately without a pill-free interval. So always remember, when a woman rings you up or presents to you missing 2 or more pills, with 1 pill it's always easy, simple. Take the tablet, continue as usual, no worries. 2 or more is a problem. First of all, how to continue the method? We mentioned that. But still, we need condoms or abstinence for 7 days. You need 7 pills in a row. Emergency contraception with the first 7. Second, 7 tablets, no need. The third, omit the pill-free interval and start a new packet. We have other hormonal contraception. We mentioned combined and we mentioned the progestogen only method. سوري الغياب كله بعتوه صح؟
أنا بعث دكتور.
بس A6 اللي أنا بعتها. أوكي.
صحيح.
Progestogen only contraception can be either progestogen only pill, injectables, implants, or intrauterine system, or Mirena, Mirena. Progestogen only pills include 28 tablets. 28, to remind you that this pill is taken daily at the same time for 28 days, and then we start a new packet. There is no pill-free interval. With the combined pills, we use 21, then 7 days free interval if there is no placebo. The same applies to combined pills. They should be taken daily at the same time. But the restrictions are more with progestogen only pills. Should be taken exactly at the same time daily. We have 3-hour window. If a patient is late by 3 hours, then we need to discuss backup methods. In Jordan, we have Slinda, we have Cerazet, we have other progestogen only tablets بسموهم بالعامية mini pills أو حبوب الرضاعة. Cerazet probably is a good option because it contains desogestrel, which may inhibit ovulation up to 97–98%. And this means that we have a longer window, longer than 3 hours. If the patient is late more than 3 hours, we're still safe. We have other progestogen only methods, injections and implants. But these are counted as part of the long-acting reversible methods of contraception. Long-acting reversible methods include non-hormonal and hormonal. Non-hormonal IUCD, copper IUCD. Hormonal IUS, levonorgestrel IUS, Mirena, progestogen-only injectables, and progestogen-only implants. So whenever women ask you for long-term methods of contraception, think of these rather than pills. IUCD, Mirena, different types of intrauterine devices. If a woman becomes pregnant on top of an IUCD, the first step is to rule out ectopic. And then, if this woman is less than 12 weeks pregnant and the thread is visible, we remove it, keeping in mind the small risk of miscarriage when we remove the IUCD. And this minimal risk should be explained to the woman, because even though this pregnant is unplanned, it can be wanted and she does not want to take the small risk of a miscarriage. If we keep the IUCD in, still you have to explain to the woman that there is increased risk of second trimester miscarriage, preterm delivery, and infection. Always, it is important to counsel women and document your counseling in the patient's notes. What I want to say is the risk of ectopic pregnancy in general does not increase when we use the IUCDs. On the contrary, IUCDs are a method of contraception to prevent pregnancy. But if pregnancy occurs, you have to rule out ectopic pregnancy. Other progestogen-only methods that are long-acting and reversible methods are the injectables. Depo-Provera, which is used every 3 months, intramuscular or subcutaneous injection. طبعا intramuscular 150 milligrams and 104 milligrams subcutaneously. It can be given immediately after miscarriage, induced abortion, after delivery, regardless of the breastfeeding status.
Alhamdulillah.
Norepinephrine enanthate is given 8 weekly, and this is not available in Jordan. Implants. Some of you examined the woman at Prince Hamza Hospital and felt the implant, single rod, releasing etonorgestrel, and it can be kept in for 3 years. Those who examined the patient noted that the implant, which is a rod-like مثل عود الكبريت, موجودة over the triceps about 8 to 10 centimeters from the medial epicondyle of the humerus. Disadvantages of all progestogen-only methods are changes in the bleeding patterns that can range from amenorrhea, irregular spotting, prolonged bleeding. And the other disadvantages, of course, for implants or Mirena, that these have to be inserted by a healthcare practitioner. So, what if we need emergency contraception? What if we need plan B? What if there was unprotected intercourse or failure of a method or an accident to condom or missed pill? We need emergency contraception, backup plan or plan B. في بريطانيا بتروحوا على الصيدلية and you request a plan B. it is understandable that you mean emergency contraception that can be either hormonal or copper IUCD. Copper IUCD, Mirena, is not licensed as a method of emergency contraception. If I'm saying it's not licensed, معناته if you use this method and a woman continues or becomes pregnant, then you fall for medical litigation. We don't use it. ممكن in the future for Mirena to be licensed, but currently it's not. We use copper IUCD as a method of emergency contraception. Hormonal, levonorgestrel tablets that can be either 2 tablets, 1 tablet, or Ella 1. In Jordan, nowadays we have Navila, and this is recent because till recently we used to use in Jordan the UZP method, which included using more tablets of combined pills. يعني ممكن نستعمل 4 حبات together and repeat again after 12 hours. And the problem with this method is high content of estrogen with increased risk for VTE. So Navila is available now in Jordan as a method of emergency contraception. If 1,000 women have unprotected sexual intercourse, single act, if no women took emergency contraception, 80 women will become pregnant. If hormonal contraception is used, then 10 become pregnant. If the copper IUCD is used, then only 1 woman may become pregnant. This tells you that copper IUCD is the best emergency method for contraception, emergency contraception. Sterilization is a permanent, usually irreversible method. This is very important. Whenever you counsel a couple, you need to tell them that this method is permanent, irreversible, لا رجوع, لا تراجع. When we counsel the couple, we mention options always. The other options include male sterilization or Mirena. Mirena and sterilization have a similar failure rate, which is 1 in 200. In addition to the risks and benefits failure rate of the method. Female sterilization, yes, there could be some failure rate depending on the timing of the procedure. The woman may be pregnant when we do the procedure, or you may ligate the wrong structure. You ligate the round ligament instead of the fallopian tube. Male sterilization, the failure rate is usually low, much lower compared to female sterilization, 1 in 200, and failure rates can be either early or late. And usually, if male sterilization is done, we recommend that the couple continue using whatever method of contraception they're using currently for 3 months or till we have 2 samples of sperms confirming azoospermia. Laparoscopic sterilization can be done at the time of cesarean section, or it can be done using the laparoscope. It can be by ligating the tube, and always we make sure this is the tube by checking the fimbrial end. We can use the clips, Filshie clips, rings, or we can simply cauterize. The other method using the histoscope is not used anymore. We used to insert micro insets through the tubes through a hysteroscope. بس تقريبا من 4 سنين أو أكتر, this method is not used anymore because of its increased failure rate. After 40, no contraceptive method is contraindicated because of the age on its own. Do we prefer to use combined pills after the age of 40? Well, we don't usually start combined pills after the age of 40. But if a woman started already combined pills before the age of 40 and she's comfortable, she's compliant, and there are no contraindications to use the method, then age itself is not a contraindication to continue the method. And keep in mind that the fertility rate declines after the age of 40. This is a history when women present requesting a method of contraception that may cover all methods of contraception. خلينا نسألكم كم سؤال، نحكي كم سيناريو. نوال، ننقي حدا ولا أنا أسأل؟ It seems إنه الكل حاضر هلأ، أو قلت لي أنتم 107؟ أوس؟ قد إيه قلت لي عددكم؟ السؤال الأول: What initial information would you want to know before prescribing the pills? يعني السؤال what relevant history, initial information.
اوكي.
الله أكبر.
ممكن
الله
اول شيء
أكبر.
نشوف اذا المنسس سواء ريجولار ولا لا.
Absolutely.
ممكن نسأل لو في اي contraindications او medical issues.
ممتاز ممتاز.
وممكن نسأل إذا في أي methods of contraception يعني حاليا أو previous.
Absolutely correct. غيره يعني هي حاليا أكيد لسه يمكن breast feeding بلشت ما بلشت delivered 4 weeks ago by cesarean section. إذا مثل ما قال أوس, first of all she's 29 years. أول إشي بلش أخذ menstrual history. بس أنا بدي أقول لكم عشان ترتبوا أفكاركم بالذات بالامتحانات لما نقول لك take relevant history, confirm the age, بعدين immediately ask about gravida para. Gravida para. How many pregnancies did she have? Previous cesarean sections, mode of previous deliveries. When was the last delivery? For this woman, her last delivery was 4 weeks ago. Cesarean section is irrelevant إذا كنا ناخد oral, بس مريضة عندها previous 5 cesarean sections and you want to insert an IUCD. It's not a contraindication, but the procedure may be a bit more challenging and requires a senior person to insert the IUCD. It's not contraindicated. بس مش مقيم سنة أولى بيجي واحدة 5 cesarean بحط لها IUCD. Okay? Keep it in mind. إذن the age of the patient is 29, gravida para, mode of previous deliveries, when was the last delivery, and Is she breastfeeding or not? Does she want to breastfeed or not? This woman had her delivery 4 weeks ago and she does not want to breastfeed. Menstrual history مثل ما قلنا أوس. Previous menstrual history. Does she have menorrhagia? Is she bothered by heavy periods? Because I'm going to choose a method that will be a method of contraception and will help manage her heavy cycles. You want to know her fertility plan. For how long does she want to delay pregnancies? بدها شهر شهرين 6 أشهر سنة ولا بدها 5 سنين? You go for with longer durations, you go for long-acting reversible methods of contraception. اللي بده يسأل على medical history. Medical history, migraine with without aura, epilepsy, risk factors for cardiac disease, VTE, and if she's on medications. عايش كمان نسأل sexual history, risk for STI. طبعا with combined pills, you need to tell women if they are at risk for STI that combined pills do not protect. Then the woman needs to use condoms at the same time, mechanical, to prevent STI. إيش في إشي تاني مهم جدا نسأل عنه؟ smoking. Smoking. طبعا smoking إذا عمر الست دايما 35 قبل ما أسأل أي سؤال أول سؤال بقولها are you a smoker؟ لا بتأرجلي؟ yes. تمام بتأرجل يعني she's a smoker عمرها 35 معناته بحط X على combined hormonal contraception. Smoking is absolute contraindication after the age of 35. Before that, smoking is, I would say, relative contraindication. It depends on the other risk factors. نعم يا تولين. تولين أكيد علشان قلنا غياب مش غياب. استني لما أكمل جملة مفيدة. نعم يا تولين.
يعطيك العافية دكتورة، أنا آسفة على المقاطعة، بس كنت أسألك إنه أنا تولين حطيتيني غياب.
تولين نعم أنت غياب لأنه زملائك بعتوكي غياب. بعدين بصير نخلي أسئلة الحضور والغياب مش داخل الكلام المهم لأنه هذا إشي ممكن الواحد يتعدل.
خلص حاضر دكتورة أنا آسفة.
الحكي ينطبق على الجميع بليز.
اللهم صل
إذا كان عمرها إذا قلنا 35 أول سؤال دائما
اللهم
بسأل
صل على محمد
smoking.
وعلى
If she's a
آله
smoker,
وصحبه
I
وسلم.
wouldn't give her combined hormonal contraception. السؤال when will you advise نوال to start the pills؟ كمان أسبوعين. ليه؟ لأنه you wouldn't start combined hormonal contraception before 6 weeks after delivery, regardless, vaginal, cesarean, it doesn't matter. Because of the risk of VTE with the estrogen. What basic physical exam will you register in your notes? Blood pressure and body mass index. Why blood pressure? Because when you give combined pills, the estrogen, the ethinyl estradiol increases aldosterone production, and this causes sodium retention. And when the woman presents for follow-up after 3 cycles, you check if she's compliant, check for any side effects, any complications, and again you're going to recheck blood pressure, body mass index, and make sure this woman is eligible to continue the pills. Non-contraceptive benefits, long list موجودة عندكم to be able to talk about non-contraceptive benefits. Catherine is a 28-year-old lady who presents to the outpatient department requesting an IUCD to be inserted. What initial information do you need? نفس الفكرة. Relevant history, initial information. What information would you document in your notes? كلها نفس السؤال. لو كان السؤال, how would you approach this lady? Firstly, start by taking a history, relevant history. Gravida para, mode of previous deliveries. When was the last delivery? Is she breastfeeding? What is her fertility plan? For how long does she want to delay pregnancy? When was her last menstrual period? And if the last menstrual period was normal, and the menstrual history, make sure she does not have any evidence of abnormal uterine bleeding. Assess her risk for STI, sexual transmitted infections, and ask about previous contraception. نفس الشيء سألنا previous contraception مثل ما قلنا aus with a previous patient who requested combined pills. If she had her baby 3 weeks ago, when will you insert the IUCD? Actually, we're going to stop asking this question because the IUCD can be inserted immediately after delivery. We don't need to wait. But still, in our current practice, we wait for 6 weeks after delivery to allow some time for the uterus to go back to its normal size. So we can insert the IUCD immediately after delivery. You can say 6 weeks post-delivery, whatever, both are correct. What is your follow-up plan? When will you bring her back? We usually bring the woman back after 4 to 6 weeks. Why 4 to 6 weeks? Because you want this lady to have a cycle before seeing her again. If she has a heavy period, the IUCD may go out, expulsion may occur. So when she's back, 4 to 6 weeks after inserting the IUCD, you do a speculum exam to check the thread of IUCD and possibly an ultrasound. Ultrasound is not mandatory and it is not available at all units. في المراكز الصحية ومراكز الأمومة بيعملوا speculum exam to check the thread. Only and only if they have a suspicion, they go for an ultrasound. But if ultrasound is available, is it okay to do an ultrasound to make sure that the IUCD is in situ? Yes, it is. If you cannot see the thread when you do the speculum exam, what is your differential diagnosis and what are you going to do next? If you do a speculum exam and do not see the thread, it means either this IUCD has come out, or there was perforation, or this woman is pregnant and the IUCD is pulled up, or the thread was short from the early beginning and this is why you cannot see it. What should you do? First, an ultrasound. If you do an ultrasound and you see this IUCD, you see this picture, this means it can be short thread. This is reassuring that the IUCD is in place inside you. If you do an ultrasound and you do not see the IUCD, then you do abdominal X-ray. Why? To see the copper IUCD. The copper is radio opaque. This is not the same with Mirena. Mirena is a bit, again, more challenging to be checked by an ultrasound. Usually we go for a transvaginal scan. This is a copper IUCD and this is Mirena. It looks different and physicians should have experience when following up women with Mirena. And this is a Mirena when we did a histoscope, checking inside the cavity. Okay, these are different scenarios to help you think when you study contraception. The first scenario, You have a 37-year lady, 6 weeks post-delivery, after giving birth to her 4th child by a cesarean section. She is healthy, but smokes 20 cigarettes per day, and her menstrual cycles are usually heavy and painful. What is the method of choice for this woman? متطوعين بدي. لا متطوعين أبداً. صقر.
دكتورة، أول إشي إحنا بنطلع على العمر وإنها مدخنة، فما بنعطيها الكومبايند بيلز.
Good thinking.
وفي كمان عندها heavy bleeding، فممكن نفكر نعطيها إشي إنه يخفف عندها البليدنج بنفس الوقت.
اللي راح يكون إيش؟ For
أتوقع
this woman ميرينا.
ميرينا.
هذا اللي كنت راح تحكيه؟
كنت أحكي الانترليوتين ديفايس بس
لا not the copper. ميرينا. هرمونال IUS. اوكي good thinking. يعني بلش قال لي عمرها 37 and she's a smoker. معناته combined is contraindicated. I'm not going to talk about combined. ليه؟ لأنه one of the non-contraceptive benefits for combined pills or combined methods is to decrease blood loss. But this is not suitable for this woman because she's a smoker and 37. فإذا I need to use another method that may also decrease her blood loss, and the method of choice for this woman would be Mirena. Okay, next. 29-year woman experienced a first trimester uncomplicated miscarriage 2 weeks ago. She would like to get pregnant again but wants to delay pregnancy for a few months. She's concerned about taking hormones and wants a method that provides some protection against STI. Lujain, what would you recommend?
Probably condoms.
Yes, I agree. Mechanical contraception. Condoms is the method of choice. Okay. A 40-year woman diagnosed to have breast cancer in the last year. She had 4 children and feels strongly about not having more children. What would you discuss with this woman? Sham?
دكتورة كبر IUD.
Well, لما يعني هو بنفع كبر IUCD, it's not contraindicated. بس لما تقول لك feel strongly about not having more children. She does not want to have children at all. ممكن تستعمل Yes, absolutely. Sterilization. Female sterilization. Agree. 26-year lady, 4 weeks post-vaginal delivery of her second child, asking you about breastfeeding as a method of contraception. Advise her about this method, mentioning the failure rate. متطوعين حكيناها قبل شوي. تولين، وين تولين؟
هيني دكتورة.
يلا تولين، إيش رأيك؟
عن إنه lactating.
نعم. هاي ست delivered 4 weeks ago and she wants to breastfeed. وبتقول لك is breastfeeding adequate? Can I breastfeed on and not take any method for contraception ولا لا؟ فممكن تقولي لها لا وممكن تقولي لها yes. شو رأيك تولين؟
أنا بقول
إذا
yes.
قلتي لها yes provided what؟ يعني there are 3 conditions for breastfeeding to be effective on its own اللي بنسميه lactational amenorrhea.
أنا said
lactational
pre-amenorrheic for 6
واحد
months
amenorrheic واحد
for 6
اثنين
months.
أول 6 أشهر 3 exclusive breastfeeding. لازم يكون عندنا 3 conditions 3 criteria. تمام؟ طيب what is the failure rate؟ less than 2%. لأني قلت لكم 98% of women will not become pregnant if they have the 3 criteria. Okay. طيب 29-year lady, para 2, both were vaginal deliveries. She's healthy, non-smoker, but gives you a history of longer cycles. Longer cycles شو يعني؟ يعني infrequent cycles. Acne and hirsutism. Her body mass index is 27. She wants a reliable method of contraception. Which method would you recommend? نور سامي.
دورة أنت حكيتي الديان أزبط وأنفع إشي يعني رح يزبط معها أكتر إشي.
إذن الديان, yes, I agree. Diane contains what? Cyproterone acetate and ethinyl estradiol. Cyproterone acetate is anti-androgenic. So this woman needs a reliable method. We have combined pills. And she also has hirsutism and acne. So these are non-contraceptive benefits to manage. طيب هذه شفتها بس لإلكم علشان تشوفوا please be careful المسجات اللي بتنزل على السوشيال ميديا. واحدة كاتبة يعطيكم العافية دكتوراتي النسائية إذا ممكن تطمنوني عم بسمع إنه ما بصير الوحدة تاخد حبوب منع حمل من بداية الزواج قبل ما يصير عندها حمل ولو لمرة واحدة وإنه بيأثر عليها وممكن يعمل infertility. صحيح هالحكي؟ أنا قريت لكم قراية. what do you think? Is it صحيح? It is not صحيح at all. آريتاج.
no لأنهم reversible يعني.
Absolutely they are reversible. مرح شو بدك تحكي لنا؟
أنا بدي أحكي إنه هي ما بتعمل أو ما بتأثر ما بتعمل infertility أبداً، بس مشكلتها إنه لو كان في أي disease فهي بتعمل delayed للdiagnosis لهذا الdisease.
هو الفكرة مرح الجملة اللي حكيتيها if there is a cause مش disease خلينا نقول cause for infertility it wouldn't be diagnosed. ليه؟ لأنه أصلاً ما كانت مفكرة she's not planning to become pregnant. This is why she's not checking if there are any problems or not. But it's not the pills that cause subfertility. On the contrary, once women stop the pills, their fertility rate go back to normal immediately. Except for one method where there is delayed return of fertility, which is the injections with Depo-Provera. مشان هيك وحدة بتقولي short term contraception بدي أجل الحمل وحدة newly married and she wants to delay pregnancy. I wouldn't recommend Depo-Provera. ليه؟ لأنه once she stops Depo-Provera injections there is evidence that there is delayed return of fertility. ونفس الشيء اللي بيقولوا لها إنه ما تاخدي بيلز ما تاخدي IUCD الدكتور مو شاطر ما بيخاف الله. No, this is non-scientific, non-academic, non-medical. حكينا دائما لازم يكون medical, academic with an evidence. For newly married women they can use any method. But we don't go usually for IUCDs, not because they are contraindicated, but for women's comfort. That's all. And they do not cause long-term subfertility. Okay. أسئلة على الموضوع؟ أتخيل لو سمعتوا المحاضرة المسجلة، سمعتوا discussion I think this is fine. اللي ما عنده سؤال هلأ وبحب يسأل لما يشوفني مستشفى حمزة we're fine. بضل هلأ نحل موضوع الحضور والغياب يا تولين. تولين زملائك CR كتبك غياب، فهل كنت حاضرة من البداية ولا تأخرتي؟
والله دكتور تأخرت صراحة 3 دقايق بالضبط، يعني صراحة
حطينك 10:03.
لا 10:14 أنا فتت، حكيت مع حازم هلا حكينا يعني.
احنا بلشنا على 10 يا بنيتي.
والله عارفة دكتورة أنا آسفة.
طيب هلأ في غيرها غايب لتولين، لأنه إذا قلنا 3 غياب تولين مصطفى محمد جردات وفراس، في كمان حد غايب، هو فعليا راحوا 2. ثلاثة غياب زملاء CRs، في 3 غياب. معلش تتأكدوا again. اوكي، لانه في حدا كان موجود وطلع من الاجتماع. طبعا بالاخر راح يطلع عندي attendance record fine، بس برضو CRs please تبعتوا لي الحضور والغياب. هلا let's talk about the second topic اللي هو menstrual cycle أو actually abnormal uterine bleeding. abnormal uterine bleeding. الناس اللي داوموا في حمزة شافوا that this is a common problem. Okay. هلا whenever we describe a menstrual cycle, always and always we have to describe it by 4 parameters: frequency, regularity, duration, and volume. Okay. Frequency means the length of the cycle. The length of the cycle is زي ما سمعتوا بالمحاضرة in your recorded lecture 28 plus minus 7. هون أنا شو كاتبة 24 to 38 days.
سبحان الله.
This is the most updated guidelines 24 to 38. لو still حكيتوا 28 plus minus 7 this is correct. And the cycle length starts from the first day of the current period till the day before the next cycle. Duration is the number of the bleeding days, and usually it's 8 days or less. The average duration of menstrual flow is between 4 to 6 days, with normal range from 2 to 8 days. Anything 8 or less is considered to be normal. Volume, this is a subjective symptom. This is what the woman tells you about her menstrual bleeding. But the objective description is between 5 to 80, with an average blood loss of 50 milliliters or 50 cc. Some references mention 25 to 50, but the average, if you want to remember it, 50, 80 mils is within normal. More than 80 is heavy loss. Let's go back to the regularity. Regularity, you need to check it over 1 year, over 12 cycles. You can check the length and difference between cycles. the difference between the longest and shortest cycles should be not more than 9 days. It is usually equal to or less than 7 to 9 days. So I expect you, when you describe a menstrual cycle, to mention the length, regularity, duration, and volume. This is a history. This is one of our patients. Her last menstrual period was on the 1st of February, and her period was for 5 days. She's used to have her periods for 5 days. ممكن تكون 4 to 5, 5 to 6, whatever. Her previous menstrual period, 3rd of January. How long is this cycle? 28. خلينا نمشي بالعكس. Last cycle, 7th of June. اللي بعديها 15th of July. This is a 28-day cycle. قبل بيومين. 15th, 12th of August. How long is this cycle? 27 days. Again, 9 September, 27 days. 9 أكتوبر, 30. 7 11 28 29 27, and this is 28 يوم. This is the length. This is from the first day of the bleeding till the day before the next cycle. طبعا في مرات بتقولوا لي الشهر 30 يوم، ماشي fine، بتحسبوا بدقة وقتها. هلا for this cycle pattern, this is regular periods for 5 days every 27 to 30 days. This is the shortest cycle and this is the longest. طبعا 28-day cycle is present in 15% of women, and it wouldn't be for all cycles. لحظة.
أستغفر الله أستغفر الله.
اوكي، في حدا له سؤال about this pattern؟ كيف حسبنا؟ واضحة صح؟ اوكي. هلا abnormal cycles are again described by the 4 parameters: frequency, regularity, duration, and volume. And whenever we talk about abnormal bleeding, abnormal uterine bleeding, we have to mention the presence or absence of intermenstrual bleeding and postcoital bleeding. Intermenstrual bleeding is the bleeding between 2 well-defined cycles or periods. Postcoital bleeding, bleeding immediately or shortly after intercourse. Frequency, again, the length of the cycle. قلنا the length of the cycle varies between 24 to 38, 21 to 35. If the period is absent, we're talking about amenorrhea. That can be either primary or secondary. رح تحكوا عنهم الأسبوع الجاي مع الدكتور فراس. Absent. Infrequent cycles معناته عم نحكي على long cycles. Long بعاد عن بعض. Infrequent cycles more than 38 days or longer than 35 days زي ما عم بحكي. Whenever you see infrequent cycles, the first thing to think of is polycystic ovary syndrome. Frequent cycles معناته the cycles are shorter cycles whenever they are less than 21 days or 24 days, and probably these are more associated with anovulation اللي بنسميهم polymenorrhea. Infrequent oligomenorrhea, frequent polymenorrhea. Regularity زي ما قلنا the cycles are irregular if you count if you found the difference between the shortest and longest cycle more than 9 days. يعني 10 أيام وأي شيء أكتر, definitely this is irregular. Duration more than 8 days, this is prolonged. معناته عم نحكي على heavy bleeding probably. Volume can be either heavy or light, and again this is a subjective symptom as described by the patient. This is an older classification. Nowadays we use the FIGO classification. Whatever is not normal goes under the umbrella of abnormal uterine bleeding. But we still use these old terms because they help us with the diagnosis. This is the normal period. This is the first day. The length ranges from the first day of the bleeding till the day before the next cycle. This is the length. Menorrhagia, regular cycles. So the first point is that it is regular cycles with increase in amount and or duration. It can be increase in the amount only or the duration only or both. Regular cycles with increase in amount and or duration. وزي ما سمعتوا في المحاضرة heavy menstrual bleeding is the same. بقول لك with effect on the quality of life وحكين سولافة. Hypomenorrhea, when the cycles continue to be regular but the bleeding days are less than 2, or minimal bleeding less than 5 milliliters, less than 5 cc per cycle. Well, this can be in some women normal, but if it is abnormal, if it is pathological, think of a Sherman syndrome, intrauterine adhesions, premature ovarian insufficiency. It could be related to stressful situations. It could be related to thyroid issues. Long list. Polymenorrhea, as we said, shorter cycles, more frequent cycles, frequent cycles. Oligomenorrhea, infrequent cycles, less frequent. Metrorrhagia, irregular, and menometrorrhagia, irregular and heavy. These are the old terms. Abnormal bleeding is common and it affects around 14 to 25% of women of reproductive age. Whenever you have a woman in the reproductive age presenting with abnormal bleeding, the first cause to be ruled out is pregnancy. This bleeding could be a complication or because of a complication of pregnancy. Once you rule out pregnancy as per FIGO classification, you think of the palm coin causes. Palm, structural, coin, functional causes of abnormal uterine bleeding. Whenever you discuss the history of women with abnormal uterine bleeding, you need to consider palm coin causes for as a possible cause for abnormal uterine bleeding. How to assess a woman presenting with abnormal bleeding? Assessment or approach. فدائما بقول لك how would you assess this woman, how would you approach the woman. This means you need to start by taking a history, doing a physical exam, investigations, and management plan for this patient. اوكي. history رح نحكي كمان شوي عن حالة، وحكينا مع الناس اللي داوموا في مستشفى حمزة. physical exam, general look of the patient, vital signs, pale or not pale, طبعا body mass index, thyroid examination, abdominal exam for scars, masses if present, we're talking about uterine masses, and then we do a pelvic exam that includes speculum and bimanual exam. Investigations، في حدا بقول لي طب بدي أبلش CBC، بصير؟ بقول له yes بصير، بس always in the gynae examination room we have an ultrasound. So this is why we started by doing an ultrasound that can be transabdominal or transvaginal. Transvaginal is more accurate, but this cannot be done in single patients in our society. So transvaginal when applicable. And it is important to do an ultrasound to look for a uterine lesion. Uterine lesion can be either fibroids and it can be adenomyosis. ممكن حدا بقول لي polyps. Yes, it depends how big the polyp is. Well, just keep in mind we do an ultrasound to rule out a uterine lesion. Do we need to measure endometrial thickness routinely? No. We measure endometrial thickness only in postmenopausal women, in those presenting with postmenopausal bleeding. We do not need to measure endometrial thickness in premenopausal women because we do not know the significance unless it is thick enough to suggest a polyp. But otherwise, we do not measure thickness in premenopausal women. وين حاطة labs؟ مش حاطة. Okay. إذن in addition to the ultrasound, we need a CBC. We mentioned the pregnancy test and also a thyroid function test, if indicated. The other investigation is endometrial sampling, and this is usually done by either DNC, dilatation and curettage. We dilate the cervix and curate the endometrium, or we do a hysteroscopy, insert a camera inside the uterine cavity and look for pathology and take a biopsy from it, or we do a PIPEL in the clinic which does not require general anesthesia. Why to do endometrial sampling? It depends on the age of the patient. Before, in the reproductive age, we do sampling to rule out endometrial hyperplasia. Endometrial hyperplasia is a pre-malignant lesion for endometrial cancer. After menopause, we do endometrial sampling for postmenopausal bleeding to rule out endometrial cancer. You need to know what is your target. Why we do endometrial sampling? Because we need to tell women. هلا المشكلة إنه بالعربي DNC تنظيفات. هاي بالعربي بنقولها تنظيفات. Women assume that this is therapeutic. It is not a therapeutic procedure. We rarely ever use DNC as a therapeutic method for acute and heavy vaginal bleeding, but we consider it as a diagnostic procedure to collect endometrial sampling. فمشان هيك بنقول للستات بدنا ندخلك ناخد خزعة تحت التخدير العام وبنوصف لها الطريقة. It is better not to mention DNC تنظيفات، ما نقول تنظيفات، نوصفها كما نعملها the procedure أو نشرح لها على الأقل. تجيك بعد أسبوعين 3 تقول الدكتورة هاي مو شاطرة لأنه عملت لي تنظيفات والدم ما تحسن. The procedure is diagnostic and not therapeutic. The procedure of choice would be actually hysteroscopy and endometrial sampling because you visualize the cavity and collect sampling under vision. Treatment: medical, surgical, medical, hormonal, non-hormonal. In the past, non-hormonal was first line treatment option, but nowadays hormonal is a first line treatment option with the Mirena IUS. Of course, when applicable, and it depends on the fertility plan of the patient. ما بزبط حدا يقول لي المريضة أو الست is planning to become pregnant، أو أنا أسألك this woman is planning to become pregnant and she has menorrhagia. What is or what medical method would you offer? You wouldn't offer Mirena nor combined oral contraceptive pills. Would you offer progestogens? Yes, because these are not, when we use norethistron acetate, cyclical or continuous, this is not a method of contraception. Or we may use non-hormonal tranexamic acid or mefenamic acid during the bleeding days only. Surgical, again, if medical, there is no response to medical treatment or the patient declines medical treatment, we may go for surgery, which includes endometrial ablation or hysterectomy to remove the uterus. Okay. Let's go for some scenarios. We have a 46-year-old woman with 3-year history of worsening heavy menstrual bleeding with regular cycles and dysmenorrhea. What is your differential diagnosis? بالذات الناس اللي داوموا في مستشفى حمزة حكينا هاي الأشياء. أفنان.
ممكن تكون adenomyosis.
Absolutely adenomyosis. وممكن شو other differential for the same lady? Fibroids. بس زي ما قالت أفنان, the first differential will be adenomyosis. دائما when you find menorrhagia and dysmenorrhea, وطبعا نحكي على parity, هون أنا قلت 46. We assume with 46 that there is increased parity. When you find the classical presentation, first differential is adenomyosis. طبعا حكيت أنا إيش كمان fibroids. Fibroids usually present with menorrhagia. But there could be congestive dysmenorrhea depending on the site of the fibroid. Okay? في حدا ممكن يقول لي هاي الست تطلع endometrial hyperplasia? Unlikely. With endometrial hyperplasia, the periods are usually irregular. لكن لما أجي أعمل للست endometrial sampling لأنه عمرها 46, أي حدا after the age of 40, we have to sample the endometrium. We do sampling to rule out endometrial hyperplasia. Okay. Adenomyosis سمعتوا عنها قبل هيك. Classical presentation, menorrhagia and dysmenorrhea in parous women. طبعا إذا قلنا 40 to 50, usually this age is because of the parity that is expected at this age. Diagnosis is usually by definite diagnosis by histopathology, and it is defined histologically by the presence of non-neoplastic endometrial glands and stroma in the myometrium. يعني adenomyosis ابن عمين endometriosis. لكن these endometrial glands and stroma are present in the myometrium. There is an ultrasound suggestive of adenomyosis when we do ultrasound for women presenting with abnormal bleeding. Fibroids are smooth muscle tumors of the uterus. Usually, they are asymptomatic, incidental finding while checking something else. But if they present with a symptom, it is usually menorrhagia. Menorrhagia increase, regular cycles with increase in amount and or duration. Presentation depends on the site, size, and number of the fibroids. Do we still need to biopsy to take endometrial sampling when we have fibroids? حدا بقول لي طب دكتورة إذا لقينا fibroids, regular cycles, do we still need to biopsy? There is some controversy about that, but تذكروا قبل شوي I told you we biopsy to rule out endometrial hyperplasia. Fibroids and endometrial hyperplasia are estrogen dependent and may coexist. This is why we always keep in mind endometrial sampling, even if you find fibroids. ليه؟ لأنه when you offer your management plan, the management options, you will need to know the histopathology. Fibroids, قلنا symptoms depend on the size, number, site, submucosal, intramural, subserosal, pedunculated, subserosal. These determine the symptoms that may result from fibroids. Type another patient, 42 years, with a 2-year history of abnormal bleeding. She's nulliparous with a history of polycystic ovary syndrome. كيف أفكر فيها هاي الست؟ هذا السيناريو. How to approach such a patient? What would you think of as differential diagnosis? أحمد حسان. أحمد حسان.
أنا أحمد حسن دكتورة.
حسن.
بدك ديفرنشال ممكن؟ سؤالك؟
نعم.
ممكن endometrial hyperplasia.
ليش؟ Why?
لأنه لها 2 years في عندها bleeding.
Okay. إذن I agree, my differential diagnosis would be endometrial hyperplasia. Why? Because of anovulation. اتذكروا after the age of 40 أو with the premenopausal changes, the cyclical patterns start to change. With anovulation, there is more exposure to estrogen. More exposure to estrogen is a risk factor for endometrial hyperplasia. This is why premenopausally women present, when they present with irregular bleeding, we think of endometrial hyperplasia. ومن شان هيك, always and always, for all women presenting with abnormal bleeding after the age of 40, we do endometrial sampling by the different methods that we've just discussed. طيب. There is another factor or other 2 factors in this patient's history that are risk factors for endometrial hyperplasia, which are being a nulliparous and having a history of polycystic ovary syndrome. This means more estrogen exposure. So yes, for this woman, endometrial hyperplasia. Mrs. Green, 43 years, nulliparous, presented with recent onset irregular cycles. The bleeding was heavy and erratic with a variable cycle length of 24 to 48 days with a duration between 4 and 12 days. Prior to that, her cycles were regular. Her periods are not associated with dysmenorrhea. She's sexually active. No dysmenorrhea nor postcoital bleeding. She's up to date with her pap smears. Last one was negative. She uses condoms for contraception and she feels well in herself with no associated mood changes or hot sweats. She is or she was a non-smoker. What are the possible differential diagnoses? What is your possible differential diagnosis for this patient? First of all, هتقولوا لي anovulation and endometrial hyperplasia. Anovulation, she is 43, perimenopausal. Previously, her cycles were regular. And currently, she has irregular cycles. You can tell from the length of the period. And they are heavy, lasting more than 8 days. So if you want to use the older terms, metromenorrhagia, irregular and heavy. You have to do investigations, endometrial sampling to rule out endometrial hyperplasia. Do we need a pregnancy test in this woman? Yes, always and always we have to rule out pregnancy. طيب. Endometrial hyperplasia is defined as proliferation of glands of irregular size and shape with an increase in the glands to stroma ratio. لاحظوا, it is proliferation of the glands, change, increase in the glands to stroma ratio. This is not an ultrasound picture. فما حدا يقول لي with increased thickness يعني عم نحكي على endometrial hyperplasia. أبداً. Endometrial hyperplasia is a diagnosis by histopathology. مش دكتور النسائية بشوفها by ultrasound. لا. طبيب الأنسجة, histopathologist, is the one to tell me about the presence of hyperplasia. Hyperplasia in the past used to be categorized into simple and complex with without atypia. Simple proliferative lesion with minimal glandular complexity and crowding with abundant stroma. On the other hand, complex hyperplasia represents a proliferative lesion with severe glandular complexity with minimal stroma between the glands. Nowadays, we don't use simple nor complex. We just say hyperplasia with or without atypia. Atypia is the most important prognostic factor for progression to endometrial cancer. And cytological atypia refers to enlarged epithelial cells that are hyperchromatic with prominent nucleoli and increased nuclear to cytoplasmic ratio. If you have endometrial hyperplasia, we did a biopsy and the result came back to be endometrial hyperplasia. We agreed that endometrial hyperplasia is a pre-malignant lesion. Pre-malignant lesion of endometrial cancer. But what happens if the histopathology is endometrial hyperplasia? What if we didn't treat it? If untreated, the fate would be for endometrial hyperplasia without atypia is to progress to endometrial cancer in less than 2% of women. And again, if untreated, they may regress. Endometrial hyperplasia may regress on its own in the majority of cases, 80 to 90% of women. So the fate of hyperplasia, if untreated, is either progression into endometrial cancer or regression back to normal. In the presence of atypia, the progression rate, if untreated, is more than 23%, and the regression rate back to normal is much less. Hyperplasia without atypia is a pre-malignant lesion that may progress if untreated in less than 2% of women to cancer. And this usually takes long time, around 10 years. يعني في العيادة بتجي لي ست endometrial hyperplasia without atypia، أعطيتها مثلا medical management or she did not want medical management، باجي بقولها the surgery is or should be immediate or urgent، ولا بتقولي بصير استنى أولادي يخلصوا امتحاناتهم؟ بقولها يس، ما في مشكلة، رتبي أمورك، استني لعطلة الصيف، استني لما بناتك يجوا من برا، that's fine. It's not an urgent procedure. It's not yet malignant. It's a pre-malignant lesion and it takes long time to change into endometrial cancer. The case is not the same in the presence of atypia. In the presence of atypia, hyperplasia with atypia, it may progress to endometrial cancer in 23% of women over 4 years duration, so shorter time. And the other problem with the presence of atypia, that endometrial cancer may coexist in 30 to 50% of cases of atypical hyperplasia. Then it's not only increased risk of changing or progressing into endometrial cancer, but also endometrial cancer may coexist in 30 to 50%. How to manage women with hyperplasia? Options depend on the age, presence of atypia, fertility plan, and the surgical risk. Women, when they present with hyperplasia without atypia, options of management: medical, surgical. Medical, progesterone, hormonal, high dose progesterone or Mirena. We leave it in for 6 months, or we give high dose progesterones for 6 months, and then we repeat sampling after 6 months. If it is back to normal, that's it. We repeat it again after another 6 months to make sure that the histopathology is benign, no hyperplasia. Or if it is after 6 months of treatment, came back to the histopathology is with hyperplasia, this means the patient did not respond, we have to go for surgery. Surgery means hysterectomy. Those with atypia, if they completed their family and there is no decision for more children, we go immediately for surgery. The problem is with those who want to become pregnant or decline surgery, we give high dose progesterones for 3 months, 3 أشهر, and then we repeat sampling. لاحظوا هناك 6 أشهر قدرنا نستنى، هنا 3 أشهر 3 months and repeat sampling.
سبحان الله وبحمده سبحان
Another
الله
scenario,
العظيم.
66-year lady, nulliparous. She had her menopause at the age of 55. She presented with bleeding. Prior to menopause, she had irregular menses, but she did not receive any hormone replacement therapy. Past medical history is significant for diabetes, controlled with oral hypoglycemic drugs. On examination, her body mass index is 35, blood pressure 150/90, her physical examination, chest, heart within normal, body mass index on the 35, obese, no masses nor scars. On abdominal exam, pelvic exam is within normal. السؤال الأول, what do you call this bleeding? Postmenopausal bleeding, صح؟ مظبوط، قلنا كلهم under the umbrella of abnormal uterine bleeding, but this is called still postmenopausal bleeding. فإذا سألتك معناته specifically بدي أعرف منك this postmenopausal bleeding. What is your main concern for this woman? My main concern is endometrial cancer. لاحظوا لو كانت 46 سنة you biopsy to rule out endometrial hyperplasia, But for postmenopausal high set, my main concern is endometrial cancer. What are the risk factors for this woman? أول إشي her age, she's 66, menopausal. Menopause at the age of 55. في حدا بقول لي late menopause relatively، بقول لهم ممكن. برضو إيش في عندها؟ diabetes and association with endometrial cancer. She is obese, she is hypertensive. So all of these are risk factors for this woman. Which investigations will you arrange for this woman? Transvaginal ultrasound to measure endometrial thickness and manage accordingly. طبعا في هاي الست endometrial sampling, whatever the endometrial thickness is. Why endometrial sampling? To rule out endometrial cancer. طيب لما نعمل transvaginal ultrasound to measure endometrial thickness, when would you say that the thickness is significant? معناته our cutoff point is 4 millimeters. If it is less than 4 millimeters in low risk women for endometrial cancer, reassure the woman that most likely her bleeding is because of dryness, atrophy. But if she has recurrent episodes, even if she's low risk, you have to biopsy. هلا هاي الست 66 years قلت لكم إنها obese, hypertensive, diabetic, presents with postmenopausal bleeding. If you do a transvaginal scan and endometrial thickness is 3, less than the cutoff point, can you reassure her because the endometrial thickness is less than the cutoff point? No, you still have to sample because this is the high risk woman for endometrial cancer. Mrs. Black, 45 years, presented to the gynae clinic complaining of abnormal bleeding. What investigations would you request for this woman? متطوعين. لا متطوعين. نغم؟ نغم تفضلي.
دكتور
تفضلي.
شيء ترانسفاجينال التراساوند.
نعم.
بشوف الاندوميتريال ثيكنينج وممكن اعمل سامبلينج اذا كان على
لا
ميكات
اتفقنا. نغم اتفقنا we don't want endometrial thickness for premenopausal women صح؟ قلنا we do an ultrasound to rule out uterine lesion. We're looking for fibroids or adenomyosis. We don't check the endometrial thickness. Endometrial thickness is only for postmenopausal women. إذن أول إشي I agree an ultrasound scan. بعدي غيره. غير نغم. دانا عاطف. دانا.
دكتورة ممكن نستعمل pregnancy blood test؟
مش ممكن أكيد. We have to do a pregnancy test. We have to rule out pregnancy. لأني قلت لكم pregnancy is the most common cause of abnormal bleeding in the reproductive age. ممكن حدا يقول لي thyroid function, yes, CBC and endometrial sampling. إذن what investigation? Transabdominal, transvaginal ultrasound to rule out uterine lesion or uterine cause, pregnancy test, CBC, thyroid function test, and endometrial sampling. What are the methods for endometrial sampling? حكينا في 3: DNC, hysteroscopy, and endometrial sampling, and PIPEL. The procedure of choice would be hysteroscopy because you visualize pathology and collect sampling under vision. طيب. 25-year-old woman presents with a history of dysmenorrhea since menarche, which initially improved with combined oral contraceptive pills. She now has pain throughout the month with cyclical exacerbations. For the last 3 years, she has also had severe dyspareunia. What is your diagnosis, Iman Abdullah?
ممكن endometriosis.
أكيد endometriosis. فدائما there are words, there are clues to suggest the diagnosis. يعني باجي بقول لك إنه هاي الست, this couple presented with infertility, this woman has 3 cycles per year with acne, her body mass index is 28. What is your likely diagnosis? بتقولوا لي polycystic ovary syndrome. What is your first investigation? Semen fluid analysis. لأنه قلت the couple presented with infertility or subfertility. طيب لو قلت لكم هاي الست 25, 24, whatever, nulliparous, presented with chronic pelvic pain or pain for 1 year, lower abdominal pain, pelvic pain for 1 year, and she's trying to conceive. خطر ببالي إذن infertility, chronic pelvic pain at this age. أول إشي يخطر ببالي endometriosis, dysmenorrhea, secondary dysmenorrhea, deep dyspareunia in association with infertility. Your differential diagnosis, your differentials should include endometriosis as the first one. اوكي تمام. في اي سؤال على اللي حكينا؟ تمام. اذا خلصنا موضوعين، بدي اعطيكم 5 ولا 10 minutes نحكي اخر موضوع menopause، راح يكون سريع ان شاء الله تعالى. اعطيكم 5 دقيقة. اوكي 5 دقايق ونرجع.
الحمد لله رب العالمين. الحمد لله رب العالمين.
Hey everyone, in this lesson we're going to talk about preeclampsia. So what is preeclampsia? Preeclampsia is a pre-existing or gestational hypertension with new onset proteinuria and or end organ damage, and we'll talk a bit more about what this end organ damage is a little bit later. So it's estimated that about 4.6% of pregnancies worldwide are affected with preeclampsia. And preeclampsia is important to recognize and treat because it can lead to significant and deadly outcomes. One thing it can lead to is what's known as HELP syndrome. HELP, H stands for hemolysis, the EL stands for elevated liver enzymes, and the LP stands for low platelets. This is a syndrome that is typically believed to be a subset of preeclampsia patients have HELP syndrome. It can also lead to eclampsia. Eclampsia is a seizure disorder. We'll talk about more about this in another lesson. Preeclampsia can also lead to fetal demise through rupture of placentae. And preeclampsia can also lead to maternal end organ damage and dysfunction. So when we look at the risk factors for preeclampsia, there's a large list of risk factors. One is nulliparity. So a woman having their first child is at an increased risk for preeclampsia than a multiparity female is. Another risk factor is having a previous preeclampsia pregnancy. So anybody that has had pregnancies in the past with preeclampsia are at increased risk for preeclampsia. Another risk factor is advanced maternal age, generally greater than the age of 40. There's also some evidence to show that perhaps younger women below the age of 18 are at increased risk, so an early maternal age, but this has not been completely borne out in all data. Another risk factor is family history, so there may be chronic and anemia. Another risk factor is having systemic lupus, increased in other vascular body matter preeclampsia. Well, there's some theories as to the pathophysiology of preeclampsia. When we look at the in this picture here, so if we can picture or imagine this is the uterus, so here is the decidua, here is the myometrium, these are spiral arteries. So in a non-pregnant, this is a non-pregnant case, here's a preeclampsia, and here's a normal pregnancy. So when we take a look into why, or the theories as to why preeclampsia occurs, one of the first ones is an abnormal placenta preeclampsia. The placenta doesn't burrow into the decidua of the uterus as well as it should. So you can see here in this image, the preeclampsia placenta or placentation does not go as deep as the normal pregnancy does, and is not as widened out as well. So that's one of the theories as to the pathophysiology of preeclampsia. It's an abnormal placentation. Another theory is that there's defective trophoblast differentiation. So the trophoblastic cells here, they don't differentiate properly. These are the cells that are responsible for burrowing into the decidua of the uterus, or the endometrium of the uterus, and they don't differentiate appropriately or adequately. Another risk factor is there's a failure to remodel the spiral arteries of the decidua and the myometrium, which normally occurs early in pregnancy. So usually the trophoblasts are involved in remodeling the spiral arteries, but there seems to be a failure to remodel the spiral arteries. So they all of these theories and causes are connected to each other. They have to do with trophoblastic activity, not able to burrow into the endometrium of the uterus, and not able to remodel those spiral arteries appropriately. So these are all possible pathophysiological causes of preeclampsia. So what are some of the signs and symptoms of preeclampsia? One of them is headache. So individuals that have preeclampsia or are beginning to have an...
Oh, hi there. You must be the student who is preparing for the USMLE, right? Yeah, they told me you'd be coming. So hey!
Onset of preeclampsia often note a headache. Some other ones include vision change, MATA, note. You can think of, when you think of HELLP syndrome, those also. So how do we diagnose swelling and also have hyperreflexia? Blood pressure greater than 90 on 2 occasions.
Subhanallah wa
So when
bihamdih.
we take blood pressure readings, we want to check at least twice, 4 hours apart. If we see it greater than 140 or greater than 90 or both, after 20 weeks of gestation in a previously normotensive patient, that is the diagnosis for gestational something else. One of those is proteinuria. So proteinuria greater than 0.3 grams in a 24-hour urine specimen, or protein creatinine ratio of 30 milligrams per millimole, or a dipstick greater than 1+. That will indicate proteinuria. We can also make the diagnosis if we have platelet count less than 100,000 platelets per microliter. We can also make the diagnosis if the serum creatinine is greater than 1.1 milligrams per deciliter. We can also make the diagnosis if we look at liver transaminases and they are at least twice the upper limit of normal, indicator of diagnosis of preeclampsia, or if there's any other cerebral dose of N. One, how do we treat and prevent intensives? One is labetalol. We could also use ending up fate. And the prevention of preeclampsia, so in patients with high risk factors, there is some evidence to show that high risk. The prevention of preeclampsia, so in patients with high risk factors, there is some evidence to show that with
أوكي، نحكي على menopause and hormone replacement therapy. تمام؟ شباب معاي؟ أوكي.
معك دكتورة.
كونك الشاب المسؤول، الغياب انتوا عندكم 2 لأنه تولين مش غياب، معناته مين الثالث؟
هسه بشيك من السيارات.
فراس غياب، وقلتوا لي كمان محمد جردات، في كمان حدا غايب.
هسه بشيك
CR's check. اوكي، شكرا. يلا let's start. menopause and HRT سريعين في هذا الموضوع، سهل جدا. menopause اللي هو بيحاولوا يلاقوا له مسميات كتيرة. زمان قالوا سن اليأس، بعدين قالوا لك لا خلنا نقول سن الأمل. whatever it is 12 months after the last menstrual period. It is diagnosed retrospectively. حدا حيقول لي دكتورة طب انتي in your recorded lecture حكيتي menopause is the last menstrual period. Yes, but menopause itself as a period is diagnosed 12 months after the last menstrual period. Primary ovarian insufficiency when menopause occurs before the age of 40. This is abnormal. Primary ovarian insufficiency. The average age of menopause in the UK is 51 plus minus 2 years. In Jordan is 48.5. Early menopause when menopause occurs before the age of 45, and premature ovarian insufficiency is before the age of 40 years. And in Jordanian women, smoking and argila are the most, argila smoking is the most contributor, the main contributor to early menopause and premature ovarian insufficiency. Symptoms of menopause vary from simple cyclical changes, bleeding pattern changes, vasomotor symptoms. These are the most common symptoms for HRT to be requested, and we have the intermediate symptoms of urogenital symptoms. Do we need to investigate women presenting with irregular cycles or with menopausal symptoms? If after the age of 45 they present with irregular cycles but no heavy bleeding, nothing suggestive of endometrial sampling, and she's asymptomatic for, she is symptomatic for menopause, hot flushes, insomnia, night sweats, you don't need to do any investigations because you understand that this is because of menopause, menopausal changes. The symptoms do not occur overnight, and the majority of women have their menopause over the years. We have only minority of women where menopause occurs suddenly. يعني الليلة بتنام اليوم في period, after that she does not have her periods. But most women have a change in the bleeding pattern. If between the age of 40 and 45 irregular cycles, hot flushes, they are symptomatic, but still this is early for menopause, you do investigations. Which investigations? We do FSH and thyroid function test. Before the age of 40, it is mandatory for women presenting with secondary amenorrhea to do FSH. Why is that? Because you keep the possibility of premature ovarian insufficiency in mind, and we don't diagnose it by one reading. We need 2 readings 4 to 6 weeks apart. Some references say 2 to 4 weeks. Fine. Just make sure that you confirm the diagnosis by 2 readings, and always keep in mind thyroid function and prolactin in mind. FSH is not reliable in women who are on combined or on oral contraceptive pills or progesterone-only methods, injection or implants, useless to do follicle-stimulating hormone. Premature ovarian insufficiency occurs, as we said, before the age of 40. All women with premature ovarian insufficiency should have HRT. It is not optional, or combined oral contraceptive pills till the expected age of natural menopause. ANM, age of natural menopause. If we do not give women with premature ovarian insufficiency HRT, they are at higher risk for osteoporosis, cardiovascular disease, and long list of problems. And it was found that HRT in these women with premature ovarian insufficiency does not increase the risk of breast cancer compared to women having HRT at the natural age of menopause. So the risk of breast cancer does not increase. It is mentioned that there is a resumption of ovarian activity in women with premature ovarian insufficiency. يعني إذا بدها تعطيها combined oral contraceptive pills, because ovarian resumption أو resumption of ovarian activity may occur at any time. بتضلها فترة طويلة without periods، بنقولها ovarian failure. All of a sudden, for a reason that we don't know, ovaries resume their activity and ovulation occurs. How to manage symptoms? Most commonly, قلنا acute symptoms, vasomotor or intermediate urogenital. Vasomotor symptoms, we used to think that they are short-lasting for 1 to 2 years, but nowadays we know that they may continue up to 7 years. So keep it in mind. Always and always explain the physiology to women to understand the change that they're going through. Change to habits and lifestyle. Changing for the diet, stop smoking, minimize if possible, if not cessation, stop alcohol, minimize caffeine, exercise, lose weight, look after someone's mental health, relaxation, cognitive behavioral therapy. And we may need to go for HRT. HRT, the main hormone that is required for HRT is estrogen. Why? Because all the symptoms, the pathophysiology of menopausal symptoms is deficiency in estrogen because of follicle depletion, no more follicles, no more estrogen. We start having symptoms of menopause. To manage the symptoms, we need estrogen. We go for natural estrogen. But giving estrogen on its own is only if there is no uterus. If there is uterus, then we need to give progesterones. So what determines what type, estrogen alone, estrogen only, or combined HRT depends on the presence or absence of a uterus. If there is a uterus, you have to give progesterone or progesterone actually, لأنه natural. Why? You want to protect the uterus, the endometrium. The estrogen is a risk factor for endometrial cancer, and you want to protect the endometrium by giving progesterone. Vaginal estrogen is given when there are symptoms of urogenital atrophy, genital syndrome of menopause, dryness, dyspareunia. We can give local estrogen cream, tablet, ring, whatever. But there is local estrogen. Even in the presence of a uterus, you do not need to give systemic, or you don't need to give backup progesterone. While if you give estrogen by the other routes, yes, you have to give progesterone if the uterus is present. Local vaginal estrogen, no need for backup progesterone. It is absorbed locally. Do we have alternative for vaginal estrogen? Yes, we have the non-hormonal products, the creams, oils, whatever, lubricants to manage the dryness of the vagina. Alternatives in general for HRT are less effective, but we usually tend to start with alternatives rather than HRT. If women respond, that's fine. If they don't, then we go for HRT. Or sometimes the symptoms, and mainly vasomotor symptoms, are severe enough to go for HRT from the early beginning. The alternatives can be selective serotonin reuptake inhibitors, selective noradrenaline reuptake inhibitors, most commonly used, but they are associated with nausea and constipation, but these complications usually resolve within the first week of treatment. Gabapentin is not used anymore because of the side effects, and we need high doses to manage hot flashes. Pregabalin, the same as gabapentin. Clonidine, again, has many side effects. We have the lubricants, as we said, other diet, lifestyle changes, and we have the complementary isoflavone soya products are helpful with the management of menopausal symptoms. Contraindications A, B, C, D, E. Active liver disease, breast disease, cardiovascular and VTE. وإيش ضلت في عنا DVT, VTE, and abnormal bleeding. If a woman presents with migraine, go for the transdermal route rather than the oral. Many studies arise talking about HRT and the safety of HRT. Women Health Initiative صلها مليون سنة. But the most recent update was in 2022, and they said that women who used estrogen containing oral HRT preparation for more than 5 years are at increased risk of breast cancer, coronary heart disease, stroke, and pulmonary embolism, but reduced risk of bowel cancer, osteoporosis, and fractures. One of the benefits of HRT is manage or reduce osteoporosis, but we do not use HRT for the management of osteoporosis. These are benefits. Osteoporosis أخذتوا عنها أكيد when you did your orthopedic rotation. It increases with age. And when we give HRT, we reduce the risk of osteoporotic fractures by reducing osteoclasts and stimulating osteoblasts. Remember, all menopausal women should be advised to take calcium 1 gram daily and vitamin D 1000 unit daily. طبعا في حدا ممكن يقول لي ممكن نستعمل 50,000 أسبوعي then شهري. Yes, you may. Or 10,000 weekly. Yes, you may. Just make sure you counsel postmenopausal women about their requirements, daily requirements of calcium and vitamin D. Oral HRT increases the risk for VTE, and this risk is usually highest in the first year, and it is mainly, interestingly enough, the progestogen that influences the increased risk. This is with the oral preparations. With the transdermal and vaginal preparations, there is no increased risk of VTE. If woman presents with menopausal symptoms requiring HRT, then go for the transdermal or local vaginal, because there is increase 6-folds for VTE with the oral route. So women with menopausal symptoms, previous VTE, requiring HRT, go for non-oral routes. Breast cancer, conflicting data, but usually it is related to the type of HRT, mainly progesterone, and to the duration of HRT. The most recent publication in the Lancet 2019 commented that there is no increased risk if used only for 1 year. Testosterone is used to manage symptoms of libido, reduced libido, and studies showed it may be beneficial for energy, mood, and muscle weakness. This is a scenario for a 49-year-old woman who complains of regular cycles over the last 6 months. She feels inadequate, vaginal dryness, difficulty sleeping, and episodes of warmth and sweating at night. Her blood pressure 120/68, pulse rate 80, afebrile, thyroid within normal, heart and lung unremarkable, pelvic exam unremarkable, up to date with her smears, and it is negative. What is your most likely diagnosis? These are menopausal symptoms or symptoms of menopause, or actually perimenopausal symptoms. لأنه في حدا منكم رح يقول لي this woman is not yet menopausal because her last period was 6 months ago. So yes, perimenopausal symptom. Do we need any investigations? No. Unless you have suspicion for a thyroid disease, no need for any investigations. A 50-year-old woman presents with hot flushes, طبعا hot flushes or flashes, night sweats, mood swings, and lack of energy for the last 3 months, which are increasing in intensity and severity. Her menstrual cycle is irregular with intervals between 1 to 3 months. How would you approach this woman? approach دائما معناتها history, physical exam, investigations, whatever is required, and plan of care. History, take a menstrual history, detailed menstrual history, gynae history, gravidaria, details of the symptoms, medical history, medications, sexual history, and the effect of these symptoms on the quality of life, personal and family history. طبعا risk factors for VTE, cardiovascular disease, smoking. ليش محطوطة؟ لازم نحط smoking. On examination, check body mass index, blood pressure, thyroid exam, breast is opportunistic, and pelvic exam. Pap smear, if not up to date with the smears, opportunistic. What are the possible differential diagnoses for hot flushes apart from menopausal symptoms? Are there anything else, any medical illnesses that possibly cause, or she's using any medications that cause hot flushes? Investigations, thyroid function test, and do we need follicle stimulating hormone FSH? No, because she is 50. You don't need FSH to diagnose menopause at this age. But we will request a mammogram, if not up to date, as a baseline in case we go for hormone replacement therapy. Why? Because the HRT may cause or may lead to changes in the density of the breast tissue. So we need a baseline. Do we need a pap smear? زي ما قلت لكم, opportunistic if not up to date. Management, how to manage this woman. Explanation, explain the physiological changes in women. And you may recommend behavioral and lifestyle changes, زي ما قلنا diet, exercise, stop smoking. The exercises are usually any exercise that she enjoys, but to prevent osteoporosis in women, we recommend weight-bearing exercising, that is walking. For this woman, we prescribe HRT combined. ليش؟ لأنه قلت لكم she has her cycles. معناته she has a uterus. If she doesn't have a uterus, معناته we give estrogen only or the alternatives. Remember to give her requirements of calcium and vitamin D. طيب. Another patient, another woman who's 52 years, last period 13 months ago, presented with hot flushes and presented with sudden feeling of warmth, especially on her chest, face and neck. Hada, this is the description of the hot flushes. She sometimes have sweating associated with these hot flushes, and they occurred overnight and caused sleep disturbances. She has also some trouble functioning at work and at home. She doesn't want to take medications, and she asks you what lifestyle modification will help her overcome these symptoms. What would you recommend? بنقولها dress in layers. زيدي لبس، خففي لبس حسب الطقس اللي انت حاسستيه. يعني البسي تي شيرت فوق بلوزة، شوبتي take off your top، خلي تي شيرت موجود. Keep indoor temperature cool، مراوح، AC اللي بدكم اياه. Avoid triggering factors as spicy food, stress, alcohol, caffeine. Lose weight, diet and exercise, and we can go for alternatives. بالعادة أنا بالعيادة بقول للست اشربي كاسة من اليانسون يوميا. طبعا بقوموا الستات بروحوا بيشربوا سطل ولا بيشربوا تانك من اليانسون. كل شيء زاد عن حده بنقلب ضده، صح؟ اليانسون there is evidence that it has some estrogenic effect. فيس كاسة بيساعدها. الأشياء الثانية اللي ممكن نقولهم إياها غير ينسون، اللي هو مينوفلافون ايسوفلافون. This is an alternative اللي يقدروا يجيبوه. طبعا السوي برودكتس فيهم estrogenic effect. So when women present with menopausal symptoms or they request HRT, أول إشي نعمله take a history. Take a history, detailed history. إشي menopausal or not menopausal yet. لأنه there are some regimens ما بنستعملها in premenopausal women وأشياء بنستعملها specifically postmenopausally. منيح؟ فإذا it is important to determine is she menopausal or not. You need to understand the ideas, concerns and expectations of the woman زي ما كنتوا تعملوا in your clinical skills lab. Discuss her options, HRT options, what to use, combined ولا estrogen only, sequential, continuous, patches اللي بدكم إياه, how to use it, oral, non-oral, and who's eligible, who has contraindications for use. Check advantages, disadvantages, and risks. Risks actually in a possible complications. Body mammogram is a baseline. Blood pressure and body mass index always are important, and when you bring the patient back after 3 months, the same with combined oral contraceptive pills, you recheck them and check for the possibility of side effects. Any questions? Questions? اللي بعتولي هاتات شكرا، واللي بعتولي تزقيف شكرا، واللي بعتولي thumbs up شكرا. الحضور والغياب، في حدا هلأ دخل على الاجتماع؟ اوكي ما في مشكلة، في عندي attendance record ببين طبعا. نعم يا أفنان اسأليني.
دكتورة يعطيك العافية.
يعافيكي.
عندي سؤال على المحاضرة الماضية، إنه لما حكيتي إنه الإندومتريال سامبلينج بنعيدها بعد 3 أشهر و6 أشهر، هاي حسب الفيرتيليتي بلان؟
لا لا لا، هذه إلها علاقة presence or absence of atypia. هلا قلنا endometrial hyperplasia without atypia is a pre-malignant lesion، لكن الشانسز أقل من 2%. endometrial hyperplasia with atypia chances أكثر من 23% and may coexist with endometrial cancer. هلا لما نيجي نعمل medical management قلنا أول إشي without management نتوقع يا أما progression أو regression. كلمة regression يرجع back to normal، progression يتحول إلى endometrial cancer. هلا medical treatment معناها إنه نعطي بروجستيرون. لما نعطي بروجستيرون ما بعطي بروجستيرون وبس بروح المريضة للأبد، لا. You want to check the response. منشان هيك in the presence in the absence of atypia, endometrial hyperplasia without atypia نعطيها medical treatment ومنعيد ل6 أشهر and repeat sampling. Why to repeat sampling؟ منشان تتأكدي إنه did this endometrium respond or not. إذا عدتي السامبلينج بعد 6 أشهر ولقيتي إنه the same hyperplasia معناته no response hysterectomy remove the uterus. إذا لقيتي back to normal معناته there is a response وبنرجع منأكد the response is there كمان مرة بعد كمان 6 أشهر، مرتين منعيد السامبلينج. بالمقابل وحدة with atypia ideal management is hysterectomy remove the uterus، لأني قلت لكم إنه chances to change to malignancy to endometrial cancer أكثر من 23% و coexistent cancer. لكن في ستات اللي ما كملوا عيلتهم أو they don't want to go for surgery، معناته نفس الشيء بعطيهم high dose progestogen لكن ما بستنى 6 أشهر، فترة طويلة. بعيد السامبلينج بعد 3 شهور، 3، منشان أتأكد is there a response or not. إذن repeating sampling علشان أتأكد إنه there is a response to medical treatment.
تمام، شكرا كثير دكتورة.
In general, endometrial hyperplasia لما نسأل what are the options? The options are ممكن حدا يقول لي expectant do nothing، هاي بتزبط للستات with no more bleeding، كان عندها abnormal bleeding بعدين for a reason she's not complaining of abnormal uterine bleeding، فبنقدر نعمل expectant yes. The other option is medical بس hormonal اللي هو high dose progesterone oral أو Mirena. The third option is surgery. The surgical option is hysterectomy. ما في endometrial ablation with endometrial hyperplasia. ليه؟ لأنه مع endometrial ablation شو معناها؟ طبعا there are different ways. Thermal, hydrothermal, whatever, balloon. بس الفكرة إنه إحنا we burn the lining of the endometrium. معناته لو أنا عملت endometrial hyperplasia I cannot repeat the sampling after that. معناته واحدة endometrial hyperplasia expectant medical high dose progesterone or Mirena أو surgical hysterectomy. There is no place for endometrial ablation. طبعا هذا ممكن يكون سؤال multiple choice. All of the following are options for the management of this woman with this scenario. إذا endometrial hyperplasia, don't go for endometrial ablation. كانت الدكتورة دينا بدها تسأل، جاوبتك؟ دينا؟
السؤال كان بخصوص الحضور، إنه اسمه ما بين وبعدين حكوا لي إنه رجع بين.
أوكي تمام. بس يعافيكي، بس برضو هلأ في غياب 4 مش موجودين، 4 يا CRs مش موجودين. ما في مشكلة. أحيانا صعب I know CRs يبين معاكم، فبيبين معانا على attendance. يعطيكم العافية. ضل أي سؤال؟ Have a nice weekend then. We'll see you next week في مستشفى الأمير حمزة. إلى اللقاء.